And as the Clatsop County Local Contract Review Board is now meeting in session, please stand for the flag salute.
To the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
May we have the roll call, please?
Commissioner Sullivan?
Here.
Commissioner Webb?
Here.
Commissioner Nettleker?
Here.
Commissioner Tila? Excused.
Oh, yeah.
Oh, he sent an email
Excused.
that he was going to be,
Commissioner
oh, yeah.
Thompson?
Here.
Next is the agenda approval.
Madam Chair, I move adoption of the agenda.
I second.
We have a motion to approve the agenda in a second. Everyone in favor?
Aye.
Those against? The agenda is approved. Now we have presentations. The first one is Columbia Pacific Coordinated Care Organization. Please come forward.
Hi, my name is Mimi Haley. I'm the Executive Director of Columbia Pacific Coordinated Care Organization. For the record, we have offices in Portland and Seaside. Thank you for the opportunity to present. I know I've got just a few minutes. It seemed like a good opportunity to do a little bit of a past, present, and future on CCOs since we're moving into a new era with CCOs. I was asked to do this at Tillamook County Commissioners, and it seemed like they asked some really good questions, and it seemed like a great opportunity to give you an opportunity to ask questions as well. So thank you very much for the opportunity to be here. Let's see if I could make this work. Columbia Pacific CCO has been in business since 2012 when CCOs were started. At the time that they were started, there was a vision for what CCOs were supposed to do. They were...
Excuse me.
Yes.
Is our screen, oh,
Mine's working.
I guess maybe you just had to turn it on. There,
you go.
thank
There
you.
you go. Okay, thank you. Great. So there were some basic tenets of what CCOs were asked to do. Basically integrate and coordinate benefits and services. There was a recognition that the healthcare system is not a system at all, but in fact is very fragmented. They wanted local accountability and local governance for health and resource allocation. The state wanted to make sure that coordinated care organizations had standards for safe and effective care, that we really had quality programs and we could demonstrate quality outcomes. And we were supposed to do that within a global budget. In other words, we would get paid a fixed amount per month, and we had to cap our total medical expenditure increases year over year to a certain amount, no more than 3.4%. The way that the legislature envisioned that was by having CCOs basically redesign the delivery system to achieve what is commonly called the triple aim: healthier populations, improved outcomes, and reduced costs. At one point, I've been doing healthcare long enough that I can tell you that at one point there was a firm belief that you could do one or maybe two of those things, but not all three at the same time. And in fact, we are proving that we can do all three of those things at the same time. In Columbia Pacific CCO, we have a fourth aim as well, which is provider health and well-being, recognizing that if the providers are stressed and are not receiving the supports that they need for their own health, then they are not going to be able to help others be healthy as well. So we do have a fourth aim that you will sometimes hear us refer to in Columbia Pacific. A little bit of the structure of Columbia Pacific CCO, just so you have a sense. At the top is our governance structure. We have a board of directors made up of leaders of the 3 counties of the CCO service area, which is Clatsop, Columbia, and Tillamook. We have a single clinical advisory panel that is comprehensive and multidisciplinary, including nurses, physicians, behaviorists, social workers, pharmacists, dentists, et cetera, who really advise on clinical strategies. And then we have 3 local community advisory councils, 1 in each county, and a regional community advisory council as well. And these entities really make up our governance for the Columbia Pacific CCO. I report to the board of directors. If you look at the middle to lower half of the slide, you can see that we also are not only the wholly owned subsidiary of Care Oregon, which is the largest nonprofit organization providing coverage to Oregon Health Plan members in the state, with about 250,000 Oregon Health Plan members across the Care Oregon counties. Care Oregon provides scale to our little CCO because they can bundle things like claims customer service into scalable services, which saves us money because we can buy those at a reduced rate because we have they provide those services for so many members. And in addition, Care Oregon manages the physical and behavioral health benefits and manages all that within a fixed budget. We are pleased to be taking over the management of the behavioral health benefit effective June 1 of this year. So we will be able to truly integrate and coordinate across the physical health landscape and the behavioral health landscape, which we think will really propel us into the future of CCOs, as you will hear. We are also a nonprofit organization, and so the only money that we, other than the money we pay out for provision of health services, we provide a fixed amount to the 4 dental care organizations that provide oral health services and contract with them and oversee their ability to do that well. We also are required to set aside reserves, a kind of a rainy day fund, if you will, because we are an insurance company, and the money that we take in any given month or any given year may not cover the total cost of providing services to the individuals who will receive services. So it is important, and I'll come back to why it's important that we're a nonprofit a little bit later in the presentation. It's really important, though, to realize that medical care is really a very, very small portion of what influences health status. And you've probably seen this before, but 60% of what influences health status is lifestyle, behavior, environment, and social factors, education, the ability to have a living wage job, those kinds of things. And so as we think about what we are trying to do to transform and improve health, we have to go beyond just medical care and transforming the medical care system. So I like to say we're about health improvement, and we started with health care. But that's not where we stopped. So I wanted to just give you an example of the way we work. You invited us to talk about CODA and the new opioid treatment program in Seaside. So I thought I'd just give you an example of where that fits into just one issue that we've been dealing with since the beginning of the CCO, which is opioid addiction. In the realm of substance use disorders, which are many, opioid use disorder, as you well know because we talked about it recently, is a big issue for our CCO. So I don't mean to go into a lot of detail here, but really there's to even address one issue, you have to have a very broad and comprehensive approach. So we're looking at reducing opioid-related harms by treating opioid use disorder, by identifying and intervening with high-risk members, by reducing overdose deaths, and by reducing inappropriate opioid prescribing. So again, I'm not going to go into all of this, but you can see on the far right-hand side, that requires work with a lot of different organizations, with a lot of approaches to assure that people are receiving the services that they need in order to reduce their addiction to opioids and to remain in recovery. And we talked about medication as a key piece of that ability to remain in recovery. But, CODA and the CODA facility is just one of a whole array of activities that our CCO sponsors and or leads or supports with staff to address this very big issue in this environment. So we treat the individual, but we also look for the institutional and societal factors that we need to address as well. And we use a socio-ecological model This is our theory of change. It starts with the individual, knowledge, attitudes, behavior, and moves into interpersonal. So working with the individual's primary support groups, you have to go into the institutions that provide services to those individuals, community factors, and then finally, at some point, public policy change, which is what you're all about. So you could imagine, for example, we have somebody with chronic conditions, diabetes, let's say. We know that a healthy diet helps to address diabetes control, but we can't just feed the person who has diabetes. And in a family, it's much more successful if you can feed the whole family healthy fruits and vegetables. Or if you have somebody who's got toxic stress, from adverse childhood experiences, you also need to not only deal with that individual's trauma and the outcomes of that trauma, you have to think about the intergenerational nature of the trauma, you have to think about the institutions that may inadvertently re-traumatize individuals through no action of their own. And so really, you know, as an example, making sure that we adopt trauma-informed practices and help our clinicians understand what could be re-triggering for an individual. What we have found, and you know about this in this community because of Way to Wellville, is that we might start with a focus on Oregon Health Plan members, but we find that our philosophy lifts all boats because the community, in fact, is enriched through a philosophy that has a socio-ecological model of theory of change. This is just an example of the way we work. Again, I don't want to go into a great level of detail about this, but what we have found is this is information that the Oregon Pediatric Improvement Program just shared. This, what they did is they combined data, health data with demographic data, with hospital data, educational data, child welfare system data, and figured out that people may look to be healthy on the outside. So they may have little medical complexity, but in fact they may have a high degree of social complexity driven by a parental mental illness, childhood neglect, or poverty, just the inability to speak English well, and therefore not be able to advocate for themselves to receive services, parental involvement in the criminal justice system. So what you can see here is that in our population, not just here in this county, but across our 25,000 members, about 42% of our children and adolescents have a high level of social complexity. And so when you think about the theory of change, you cannot just address their healthcare conditions because in fact, you may have a child that has a chronic illness such as asthma. It's not complicated and it's fairly well controlled, but if you have 3 or more social complexity factors, it's going to be much, much more difficult to help that child stay healthy. So this is our approach to, it's a systems approach to improving health, and it is the way we work. This is just another example, and again, this is a very detailed picture. But what it does is if you move, this is just our maternal child youth strategy. So we are looking at preconception to 21 years of age. So that segment of the population that's enrolled with the CCO. From the left-hand side, we're dealing with individuals. So a child who needs specialty behavioral health. But how are we also working with the Northwest Early Learning Hub for early intervention and ECST services? And how do we integrate the services so that it's easy for the families to work on? So you go from the left-hand side, which is really dealing with the individual. You go to the institutional, which is the network and clinical services area. And then at the far right, you're dealing with whole populations. We have interventions. You can see the active interventions that we have underway at this point. Things like First Tooth, which is allowing kids to get fluoride varnishes in the primary care setting so that they don't have to go to a dentist in order to get the fluoride applied to their teeth. We have early stage work that we're doing, including youth substance use disorder strategy, and then we have things that we're going to do in the future. But you can see underlying all of these are these more foundational services that we need to assure are wrapping around our families and our kids. So we have to make sure that the services are culturally and linguistically appropriate, that people who have limited English proficiency can get an on-site interpreter, for example, that we are dealing with trauma, resilience, and adverse childhood experiences. And we are, I see Jill is here, we are improving access to parenting education resources, and then using data to inform what we do. So this is just, again, another example, but this is what health transformation looks like. This is how we think about health and not just health care. And so I just wanted to lay that out so you'd have an example of what we're talking about. I mentioned that it was important that we're a nonprofit. Aside from the money that we use to pay for claims and the small amount that we set aside to manage our rainy day fund, the rest of the money we spend in our communities. So I just wanted to give you a couple of examples of the kinds of things that we invest in. We have a community wellness fund, which really addresses the community health improvement priorities that our communities have told us are important to them. The three are obesity, overweight, with a focus on healthy eating and nutrition, substance use, and mental health. And then we also have a large grant program that focuses on clinical integration, clinical innovation, integration, community health, and prevention, with a few examples of the kinds of things that we have invested in. You can see under integration the CODA opioid treatment program, but we also provide grants to Alan Evans for Helping Hands. We have a Healthy Homes program that Clatsop Community Action works on to do environmental assessments for people who may have respiratory issues caused by mold or poor ventilation, those kinds of things. All in all, the CCO, just since 2017, I didn't want to go further back, but just since 2017 to now, in this county alone, the CCO has invested almost $3 million in these kinds of community programs. That is independent of the $3 to $4 million we put into the clinics to improve their population health programs and their ability to increase capacity to provide the services, the integrated behavioral health co-located in primary care settings. So this is the way we work. And one of my board members once said that the CCO is really just a vessel for the good work that exists in the communities, the leaders in these communities who know what they need. We're there to help support them to achieve those objectives. So CCO 2.0 has raised the bar. We had to submit an application that was about 250 to 300 pages, telling the state exactly what we were going to do to drive the next stage of transformation. I wanted you to know that we are going to be focusing on these 8 areas: early life, nutrition and food access, housing supports, trauma-informed services across all sectors, healthcare, social exclusion, social supports and stress, behavioral health intervention services, as well as behavioral health prevention. So that is really all I wanted to share with you. I've already probably taken more time than you wanted me to, but I did want to just give you a sense of who we are, what we do, why we do it, and where we're going.
Madam
Thank you. Yes.
This is a data nerd's delight, so thank you for that. I'm so impressed with the depth and breadth of your work. I'm curious, though, about your outreach or how you gather in the people who wouldn't normally be thinking about making use of your services. I'm thinking particularly of at-risk populations of severely impacted folk. I saw the phrase diversity, equity, and inclusion. I'm thinking you probably have sexual minority programs for youth as well. Just speak a little bit generally, if you could, to those.
Yeah, the way the CCO operates is, we're a partnership model. We rely on our community partners to know who the populations are and the services that those populations need outside of a clinic setting. We know what goes on inside of a clinic setting because we contract with the clinics directly. We pay them for those services. We have people who go in to the clinics and provide technical assistance to help them do outreach to specific sectors. But as a partnership model, we really rely on the communities and the leaders in these communities to understand where there are pockets of need and people who are not being seen and served. We rely on our community advisory councils to tell us that as well. And that helps to drive the focus. These areas of focus actually have emerged organically across our CCO over the past 6 years. We have already been investing in these areas. So this is not a stretch for us. This is just being a lot more focused and a lot more intentional in how we work. So I know Todd was here earlier. You know, we met with Northwest Oregon Housing Authority, said what kinds of services and supports can we wrap around people who are new to Section 8 housing so that they don't lose their housing in a year. And it was a fantastic conversation that gave us some good ideas about the kinds of things that we could do that would help in the housing sector. We can't build housing, but we can certainly wrap services around people who are in those facilities.
Thank you. One follow-up, Madam Chair?
Yes.
I love the part about provider health and well-being, because really that's the part that gets overlooked, and the services can only be as good as your providers are. Can you say just a little bit about how you see to your providers' well-being? I know you have some structural things, but what do you actually do for your providers?
We actually sponsor workshops that providers can go to, mindfulness workshops. We have a couple of different options for them if they want to go through 8 hours, or if they want to go through less intense training. But we actually pay for providers to be able to receive services and trainings that help them with mindfulness, stress reduction, those kinds of things. Our medical director is passionate about this. She is a family practitioner herself and knows what it's like to have this treadmill of patients coming in every 15 minutes and being a primary care provider and having to deal with people who have very complex needs. And so she has a personal passion about this, and this has been an area of focus for us for about 4 years since she joined our staff.
Thank you very much.
You're welcome.
Commissioner Sullivan?
Yeah, I know that we have people in the room that are familiar with CCO's work and whatnot, but would you, in your words, explain what a CCO is? What I'm understanding is that you're an insurance company, you are between the state and the providers at the local level.
Yeah.
And so when you are talking about, you had a broad range of what you're interested in, what you think is important. So how does a CCO work in that? They're the ones who decide where this money is spent. Could you talk about what a CCO is in very basic terms?
Yes, thank you for asking that question. So we have a contract with the Oregon Health Authority. We are obligated to provide all the benefits and services that an Oregon Health Plan member needs. And so that's the insurance piece, and we need to do that with a fixed budget. So we get paid a certain amount per month for all of the people that we serve, the 25,000 people that we serve, and we have to provide all of those benefits and services to that population according to the schedule of services and benefits that the Oregon Health Authority creates. In addition, though, back to the theory of change and transformation, you cannot make healthier communities by focusing just on health care. And so we have to focus on the whole community, the ecosystem of health, and whether they like it or not, educators are healthcare providers. And you know, whether they like it or not, Alan Evans is in the crisis management business. So, you know, you have to build these services and supports in partnership, and that's what the CCO does. So yes, we are an insurance company, and then we like to say, and we're so much more. So we try to provide capacity in the communities to effectuate the kinds of changes that the community leaders know.
I have a couple more questions. One is, it looks like there's a lot of data that kind of directs your decisions. Who collects that data? How does that happen? I know the way to Wellville, there was a pay for success, which I'm not too keen on, but how do you get the data for what you're I'm sure it's statewide, probably national, but also locally. Does the CCO help provide staff to get that data? How
Yeah.
does that work?
So there are kind of three major sources of data for the CCO. The first is through the claims that we pay. So as an insurance company, we know the services that we've provided, how many of them have been provided to whom, what kinds of services, hospital, outpatient,
So
whatever
you
they
pay
are.
attention to that, and then you direct your policy according to those sort of things?
I'm sorry?
When the claims, you're picking up the data from the claims that are sent to you, and then
Yes.
determining where your policy has to go from there?
We pay the claims ourselves, yes. So we have a lot of information about the services that are being received in clinics, behavioral health clinics, and primary care clinics, and hospital settings, those kinds of things. So that's one. The second is back to operating with standards and quality outcomes. We also are required to adhere and demonstrate our ability to deliver quality by being measured on about any given year, it varies, but about 17 to 19 different measures that the state prescribes. So colorectal cancer screenings, developmental screenings for children 0 to 3, immunization rates, those kinds of things. And that data we have and the state gives us. So the state has the alert database for immunizations. They'll give us information that we may not be able to collect just from our own experience. So that's the second. And the third is through these partnerships that I described, we hear from Alan Evans what kinds of services he's providing. We hear from Elaine Bruce what kinds of services they're providing, who they're providing them to, how many of them they're providing. And when we give grants to the communities, we ask them to tell us what outcomes they're looking for, and then we ask them to report on those outcomes. So those are the three major sources.
Is that part of the projects, the money that gets turned back into the community, that's based on suggestions from local, is that what you're saying?
Yes, exactly. So mostly it has been the community coming to us asking for grants to support services, they know what they need. Amy Baker, has a proposal for providing more crisis services in the community in conjunction with law enforcement. She doesn't have the budget to do that, but let's see how that could work. And it's actually working quite well. We're very excited about it. So yes, we do collect data that way from the community partners. And in addition, we have started to develop in these kinds of areas more of a request for proposal process. So we know we want to have comprehensive suicide prevention programs in each of our counties. And so we will say we would like anybody who wants to provide a comprehensive suicide prevention program in the schools, training for other workers,
Right.
Yep. So we both, they come organically, and then we also solicit proposals.
And then finally, this seems to be a change, the way the state is looking at CCOs. Can you talk a little bit about that and what you think you will bring to this new landscape?
Yeah, thank you for asking that question. In fact, I think the state looked to Columbia Pacific to figure out what they wanted at CCO 2.0, because we have had our theory of change for a long time that has focused on social determinants of health, as I showed you in that slide, and not just health care. And so the state is doubling down on social determinants of health and really expecting CCOs to figure out where they're going to invest and how they're going to invest in addressing the social determinants of health. They are prescribing that all CCOs have to invest in housing at some level. And we can also then decide where we want to invest based on the local needs of our communities, and that's really where we are going. So that's where the state is going. They are also being a lot more specific about what we have to do in the behavioral health world. They're expecting much better service delivery, much better integration with behavioral health, and they're expecting us to stop paying on a fee-for-service basis that really replicates that treadmill that we talked about with Commissioner Thompson, where it causes physician burnout. So they are looking for value-based payments, and they are saying, how are you going to sort of shift from a fee-based model to a value-based outcomes payment model? So those are the kinds of things that state is demanding with CCO 2.0. It's a heavy lift, and we are fully capable and very excited about doing it.
Thank you.
Commissioner Webb, did you have questions?
I do. I would have appreciated an org chart, being a data nerd, an organization chart, and also a budget. I have no, can you give me some numbers about what your total budget is?
Yeah,
And how it's dispersed?
Yeah, so our total budget, let me see if I can do the math quickly in my head. We're about a $150 million a year organization. That is the payments that we receive from the Oregon Health Authority. And then there's approximately $4 to $6.5 million for the quality outcomes that I mentioned previously. So that is money that the CCOs have to invest in our communities.
What does, can you explain that?
Yeah,
I'm
so,
sorry, I'm not-
so because so they pay us for services, and they also expect us to deliver quality outcomes. And so they created, in the initial version of CCOs, they created a quality pool bonus program that basically says, if you can demonstrate these outcomes, these quality outcomes, then we will pay you an additional amount at the end of the year. And that money we then use to reinvest in clinics, and we use that money to invest in our community partners as well. So that's the budget that we have. I will say in Clatsop County, in 2018, we spent about $42 million in healthcare services, and probably another 3 to 4 in alternative payments, some of these value-based payments that I mentioned. So that gives you a little bit of a sense of the budget that we're talking about.
And what is the source of money that you use to actually fund services on the ground?
And this is the beauty of transformation. So if you avoid a hospitalization by providing prevention services, you save a lot of money. Hospitals are expensive places to be. So that is that whole theory of change. You move upstream. And so with any surplus that the CCO generates, because we've been effective in managing the care for our members, any of the quality pool dollars that we get paid as a bonus from the state, those are the sources of funds that we use to reinvest in our communities.
And is that determined sort of on a, well, obviously on an annual basis?
Yes.
Okay. How many people do you serve in Clatsop County?
About 9,500 people.
And is that a, those are OHP members?
Yes.
Okay. Okay, thank you.
You're welcome.
I have just two small questions. So on the multifactorial approach of opioids, the proactive outreach, what does that look like? Can you describe that?
Let me just see if I can get my slide, because the print is too small for me to be able to. So you're asking about the,
It's over on the right column, and it's 1, 2, 3, the fourth box down in the middle.
okay.
Proactive outreach.
Right-hand side. Community, okay, so we're in the, let's go back to that slide just so that I can take a
On
look
page
where you
6.
go.
That's it.
That slide that you're talking about?
Yes.
So you're talking about the spine that is building a system of care, is that what you're talking about? Coordinate
sorry.
care among system components?
It's the 1, 2, 3, fourth box down on the right, and it says proactive outreach.
Oh, I see what you're saying. Okay, so that's part of the data-informed strategy. So, so we have a lot of data on who, how we are reaching people who want to be in recovery, who have addictions. We have a lot of data on tapering and what is an appropriate taper. We have a lot of data on prescribing how many pills are in circulation that could end up on the streets. And so we use that data to really figure out then where do we need to outreach, which pockets do we need to outreach to, and with what data to continue to advance along the line of less opioids in the community and in individuals' hands.
Okay. And my last question is...
There's one more thing I'd like to say about that, and the state is actually, Care Oregon has a dental care organization that's affiliated with us and helps provide services to our CCO as well, but the state is now adopting a very comprehensive approach to opioid prescribing by dentists, because in fact, the first incident of youth receiving an opioid is probably through an extraction of wisdom teeth. And so this state is really looking hard at how do we think differently about who has access to opioids, and data is a big piece of that. So we have data that shows, in collaboration with the dental care organizations that we work, who the dentists are that are prescribing, what the average number of pills is in each prescription, how many prescriptions they're issuing, what age of the population is that they're issuing those prescriptions to. And so that's another, for those of you who are data aficionados, I won't call you nerds or geeks, but people who love data, that's another example where we would do proactive outreach with the dental care organizations in collaboration to dentists who may not understand that they are inappropriately prescribing and that there are alternatives, such as ibuprofen, which is a much better alternative for extractions, for example.
Madam Chair, one more.
Oh, well, actually, I had another question, and then, yes. So the dental component, what is covered? Is everything covered?
Well,
that
you're
is-
getting beyond I'm a little over my skis on that one, but, because I'm not a dentist. But there are, pretty much it's from preventive services through dentures. So, screenings, those kinds of things for all OHP enrollees. A lot of adults don't know that they have a dental benefit or don't think they need dental services until they've got pain. And so, just educating people about what their benefits are is a big component of what we're trying to do right now. So yes.
And are there enough providers to offer this?
That's a good question. I would say in our service area, we need more. Dr. Tyak's practice was really the biggest practice in this community, as well as in Northern Columbia County, and he cared about the Oregon Health Plan population. There are a lot of dentists who don't believe that they get enough money on the fee schedule that the state pays to warrant the hassle factor of complying with the state requirements. So we do need to increase the number of dentists, and that's a strategy that we work on with the dental care organizations that we contract with.
Okay, Commissioner Thompson.
Thank you. So I had the chance to be out at the jail, the OYA, the jail to be, and thinking about how once someone's incarcerated, no more OHP. So fundamentally, that's a real deficiency in services. We've been talking among ourselves about, is there a difference that we can make as a county, acting in concert with other counties and perhaps cities to impact legislation going forward. So I would hope that you develop with us the
Yes.
capacity to inform our policy initiatives with our state and federal legislators. So however we can design that partnership to have an effective flow and better policies and better results and healthier communities, let's do that.
Absolutely. Absolutely at the policy level, but also at the direct service level. Could we bring medication-assisted treatment to the jails, for example, so that people can be in recovery when they are not in the community? Those are the kinds of things that we would love to talk about with you.
Heck yeah. There are a couple of guys in the audience who are interested in that, I'm sure of it. Thank you.
Oh, Commissioner Webb?
How many employees do you have?
The CCO itself has about 20. dedicated employees, but because we buy services from Care Oregon, there are, bits and pieces of hundreds of people who do, authorizations and clinical reviews and, customer service calls and processing claims. So I can't tell you exactly, but dedicated specifically to the CCO and the work in our 3 counties, about 20.
Do you have a physical presence in all 3 counties?
The only place where we have a physical presence is here in Seaside. Otherwise, we
In
have.
Astoria, actually.
We have a presence in Seaside, in this county. But we do have employees who actually, we have a Community Advisory Council Coordinator, for example, who lives in Tillamook. So we do try and maintain a presence in the communities as well.
Okay, just one more question. Can you shed any light on why the state decided to entertain more than one CCO in an area?
No, I can't. I can speculate, but it would be pure speculation. So I think that would be a good question to ask Director Allen.
Okay, thank you.
Okay. Thank you very much.
Thank you very much for the time.
Come back again soon, please.
Anytime.
Now we have another presentation from the Northwest Coordinated Care Organization.
Good evening, Commissioners and guests. My name is Kevin Campbell. I'm the CEO of Greater Oregon Behavioral Health, GOBI. GOBI has been doing business here in Clatsop County since 1997, first managing the mental health benefit as a mental health organization, and then with the formation of CCOs in 2012, joining with Care Oregon to help form Columbia Pacific Coordinated Care Organization. We've also, since that time, been an owner in the Eastern Oregon Coordinated Care Organization, which covers 12 counties in east of the Cascades. It would be fair to say that GOBI's DNA is rural. And when I came to GOBI in 2001, we had 13 employees. Today we have about 160 employees. And this is a map of where our employees live and work. They're scattered all over the state, but our philosophy is that healthcare is a full-time job, and we need to be ever present in the communities to take on the tasks regardless of when they come up. You're familiar with some of the work we've done in housing. A couple of you toured our latest project, and I want to first and foremost thank you very, very much as a Board of Commissioners for your generous contribution of that fabulous piece of property that I think is going to be a model for the state in what recovery-oriented housing can look like. We truly appreciate that. In the evolution of CCOs, one of the agreements that the state made with the federal government is that they will rebid the coordinated care benefit, if you will, open it up for competition after 5 years. They extended that to 6 years, but indeed the competition is, as you know, going on right now. And it's distracting, it's difficult, but the goal is to end up with improved systems at the end of a very long and difficult process for all of us. Greater Oregon Behavioral Health became aware of encouragement from other providers here in Northwest Oregon to one of our partners, Moda Health, to form a look-alike CCO, if you would, to what the Eastern Oregon CCO looks like over here, and made the choice to become an applicant and owner of that CCO, should it be granted the contract to do business in these 3 counties. So with that, I'll turn it over to Bonnie Thompson. But before that, I'll tell you just a little bit about myself. Grew up in a ranching family in Eastern Oregon, the other John Day Valley, not the one just out of town. My grandkids live in the same house that I grew up in, and firmly believe that rural communities can be the guiding light to what health transformation looks like, and really what better health, better care, and lower costs, which is the triple aim that the state adheres to, will never happen if you focus on costs first. You have to focus on the fabric of the community and what it takes to create better health and better care, and then costs will take care of themselves. But if you try to manage yourself by looking at the bottom line first, and you'll never get to, my philosophy is you'll never get to better health and better care. So I'll allow Bonnie to introduce herself. I think many of you know her, and then we'll move on. And you need the clicker.
Hi, my name's Bonnie Thompson, and I live in Astoria, Oregon. So, or Svensson, as we say where I down the road.
Could you speak a little closer to them?
Yeah, I sure can. Is that better? Yes. So we wanted to talk a little bit about what was different about the Northwest CCO, because it is a change, and we do know that comes with some disruption. And so the model that we've, as Kevin said, built this off of was the Eastern Oregon CCO. And what's really different about it is that this CCO will be co-owned by local community partners. So this will be basically a newly formed LLC that will be made up of local providers here in the area in all 3 counties. And we'll go into who those are going to be. But this is a really neat, because not only are we looking at a lot of partnership and making sure that we've got shared goals, we've also got a financial structure that will lead to shared accountability and risk. And so the cool thing about that, my background's working in hospitals, is that there's no way for anybody to be successful unless we're all successful. So the hospitals, behavioral health organizations, public health, everybody is going to have to work together for us to be able to do this well. And it's a model that we've seen work really well in Eastern Oregon. I think. Okay, which button? There we go. So one of the things that, looking at data that the state looks at is, are we keeping finances under control? And the state had set a target of meeting a 3.4% rate of growth over the last couple of years. And it's been hard. It's been very hard for the state to meet that. EOCCO, we actually were able to meet that this last year. We had a 2.9% rate of growth. And with that, because one of the things you want to do is balance that, is make sure we're delivering great quality of care. We also met our care indicators. So the state looks to make sure that you meet like 14 out of the 17 indicators that Mimi talked about. And we were able to meet at least 14 of those. We're still waiting on to hear about a couple. But really making sure that we're working with, again, our local providers and our local communities and our local community advisory councils on what's important in each community, because every community is going to be a little bit different. And so the way that we found that works really well, that we're going to replicate over here if we get the contract, is that we basically will give the local groups, the local community advisory groups, dollars, money, and say, how do you want to use those? Instead of the CCO itself coming back and saying, these are the things that we think you should spend it on, or needing to have everybody compete for those dollars, is each group will have some money that they'll be able to actually determine based on local determined priorities how they want to spend it. So EOCCOs use this model to reinvest millions back into local communities, and it's neat to see what the groups come up with, because they really get to set that. The CCO then helps provide the resources, maybe people support, maybe technical support, whatever they need to be able to get those things done. And it's, and I have to tell you, beginning to work with those groups is really exciting, because it's something that you hear around here, what's near and dear to everybody's hearts, and the local communities know what the issues are. So being able to find ways to be able to support that's probably one of the coolest things we do as a CCO. And then we really try and make sure that we've got local staff over in EOCCO. We've, most of the staff that are over there are local, and so they're working with their friends, neighbors, families, a lot of them, to be able to get this work done, which also, again, brings with it this, we're all going to be successful together. So here's the list of who the local co-owners are going to be. So the groups that are joining together to form this formed this new CCO, our Columbia Memorial Hospital, Adventist Health, they're out of Tillamook, Yakima Valley Farm Workers Clinic, which is Coastal Family here, and then Gobi and Moda. So again, everybody here is really vital parts of their community. They understand what the folks need. They're already working in the areas, and this gives us a way to really build the structure to work together. We, as part of our commitment to doing this, we'll be putting in what's called a health information exchange, where all of these folks have said we're going to make sure that we can share data, that we can see what's going on with our members, reduce duplication, find out where there's issues so we can deal with them quickly. We'll have a wealth of data that we can share this way, real time. If somebody's admitted to the hospital, we'll know tomorrow, so we can start discharge planning. So we're really excited about that. This is a system that we've used in the past, and it works wonderfully to help us meet our metrics as well, make sure we're delivering good quality. And then I wanted to continue some of the work that Gobi's been doing over the years. We've really found that the fun things that we get to do are working on things like putting in the North Coast Crisis Respite Center, getting that up and going. The housing is really exciting for those of you that got to see it, and that's going to be wonderful. But working on the things that are preventative, because again, the more we can get in front of issues, the more that we're not spending all of our money taking care of people that are in crisis or dealing with health concerns, but we're actually helping them live their best lives by not having to worry about healthcare crises or behavioral health crises. So I think that's it for slides, although, there we go.
We came prepared for questions.
Yes.
Madam Chair.
Commissioner Thompson?
As I understand it, there's a competition among two insurance companies. We don't decide which one is chosen, right?
Correct.
We just say, we're happy you're here, we want you to do good work, and we want our communities well-served and best value for the money. Is that it?
Actually, you do have a voice. You are the local mental health authority, the local public health authority. There are memorandum of understanding that would be expected. I think it would be very difficult for a CCO to take root in a community if the Board of Commissioners said absolutely no, we don't want them. Our goal is to work with whoever is willing to work with us to achieve the goals that the state has set out for 2.0. And while the term insurance company has been put about, I think there's a difference in Gobi as a not-for-profit. We always debated internally, are we an insurance company, or are we managing the risk on behalf of the communities? Because we were formed by the community mental health programs of rural Oregon, including classic behavioral health. And really, we've always considered those programs to be an extension of our organization as not just the delivery system, but actually the managing body of Gobi. So to say Gobi's an insurance company, it was formed to really compete with insurance companies to maintain that local control back in the late 90s. And our goal through hoping to have more diverse ownership, sharing that ownership and risk with hospitals and insurance companies such as MODA, really is to diversify out that risk model so you have both upside gain sharing opportunities and downside risk that pass through to, as in Eastern Oregon, we have 8 distinct owners, all of whom are accepting upside and downside risk. Over here, and that list is what we have to date. We have stock reserved for other potential owners should we get the contract.
So if I hear you correctly, I'm trying to translate it, so thank you for supporting my learning curve. So you're more like a cooperative then? Is that it?
That's how Gobi was formed, and that's how we feel the Eastern Oregon CCO operates, very much like a cooperative.
Thank you.
Commissioner Sullivan?
So I kind of want to ask similar questions. It sounds to me, if I'm understanding you right, the question I asked the previous guest was, what is a CCO? And I think the question that you just responded to Would you say that that pretty much defines how you see your CCO, of being a local partnership and not necessarily insurance, but try to?
Yeah, I think well, the way I see a CCO is we've been given this great pocket of money, basically, resources, and said, please take this money and figure out how to manage it in the way that's going to best enhance the lives of the people that are under your care. And so that's really our job. And if you think of an insurance company, that's not necessarily, they're not there to manage a pocket of money and say, you need to get great outcomes. You know, a lot of them are there to make money. CCOs are really designed to figure out how to best coordinate and enhance the lives of our members. And so I think that's the big distinction that I see, is that that's really what we're trying to do, is figure out what can we do to make our members' lives better, make sure that again, we're keeping costs low, because then the lower we keep costs, the more we can do, the more people that we can touch. And the other thing that's really cool about the CCOs is that we're not limited to healthcare. So if we want to use that money to buy somebody a refrigerator so they have better access to fresh foods, we can do that. And so there's a lot of different things that we can do beyond what a traditional insurance company could do with those pockets of money. It's just up to us to really help coordinate
And that's,
how it's used.
that's reinvesting the money that may be saved, which the past guest was talking about, that you get to choose how you spend that money, and so how would you choose that? It sounds like you're talking in a similar way, that you have input from local.
I think
Providers.
yes, Commissioner Sullivan, and I think that the real goal of moving from a medical care system to a healthcare system of CCO 1.0 is well underway. We all know that it's far cheaper to keep people well than it is to try to fix them up when they're sick. And we also know that medicine was an extremely competitive activity in the past and has moved more toward a collaborative model. Where we need to go now, though...
Let's move towards a corporate model.
A collaborative model, is what I said. Yes, good point. As you're well aware, the state spends 94% of its budget on education, healthcare, and public safety, health and human services and public safety. And as the governor said to me personally a few years ago, when he formed CCOs and early learning hubs, he did that, Governor Kitzhaber, he did that with watershed councils in mind. And he said, if watershed councils can bring people together and act as a convener that can get fishermen and farmers and sportsmen and environmentalists to all come around the table and invest for the public good, why can't we do that with healthcare, education, and public safety? So I believe we're on the way of doing that, but to marginalize any one player as being healthcare only, much as Mimi said earlier, we're all in the human being business. And again, coming back to that same credo that investing way upstream, investing in at least 2 generations at a time of human beings, and engaging the community in a language that they can understand and they can buy into is what the success of CCO 2.0 is going to be all about.
So I had also, Mimi, was it Mimi? The former guest, sorry, I didn't get your name first. So I asked her about the data that's involved with these kind of policy decisions. Can you talk a little bit about the data in your group?
Sure. An early decision of the Eastern Oregon CCO was to invest in a data warehouse called Arcadia Solutions. They have been around in the medical world for quite some time, but parallel to the CCO's investment, Gobi made a similar investment to create a behavioral health data warehouse that we could match up with a physical health data warehouse. And you can imagine with HIPAA and 42 CFR and other federal regulations, you can't always share all the data back and forth. There's privacy ties to certain parts of that data. But we've successfully stood up the warehouses now. The majority of our physical health providers are submitting data to the EOCCO warehouse, and every county, including the 3 here on Northwest Oregon that are Gobi members, are submitting data to our data warehouse, with the exception of one, and that's Sherman County. We're working on it, but the 350 lives in Sherman County are not included
Well,
in
it
our
takes money to
warehouse.
collect data.
Yeah,
Right, yeah.
yeah. But having that real-time data that's beyond claims data, that looks at the health record and can tell us where the service gaps are, where the redundancies are, and can import data from other data sources such as emergency rooms or the emergency department, information exchange, and others, I think is what the future is going to look like for healthcare reform. And then having the analytics, which we do, to really go through that and produce reports on a monthly basis that go not only to the medical community, but also go to the Community Advisory Council that can tell people how they're doing in meeting the metrics and also what the health status of the community looks like in a way that people can understand. Of course, it has to be de-identified when it goes to that public body, but certainly each clinic has access to their data on a monthly basis.
Isn't that part of the evidence base, the big revelation? You know, I mean, you hear that in all sorts of social interactions, to get evidence-based that moves policy forward, correct?
And I think the exciting part is the Northwest CCO owners have already made a commitment that they want to get to the same structure. I got to be in a meeting yesterday. We were actually talking with public health, all the public health officers over in the eastern side of the state about how to get them on the same platform. So truly coordinating care, not just within traditional healthcare that you would think of, but how do we start bringing in other people and other partners to start working on the social determinants of health? You guys mentioned the jail. You know, those members, they're still our members. Even if OHA doesn't officially say they are, they're still ours. We know them, we care for them, we want to make sure they're successful when they hit the ground running. And so how do we do that? How do we know when people are coming and going so that we're ready to do those things? And I think these data platforms and the willingness of all the partners to jump in and say this is a really worthwhile investment gives us those opportunities and those windows into people's lives in a way that we can intervene well.
If I may ask, the third question that I asked Mimi was, when the state is changing this landscape, what do you feel like you are bringing to it, and what's your idea of why they're making this change, and how are you going to fit into this different landscape?
Well, recognize we're in an open procurement process, and we're really not at liberty to comment, particularly with state employees present in the room, on what we see as strengths or weaknesses in the procurement process. What I can say is the decision ultimately lies with the Oregon Health Authority, and we will do our best to not only support our application, but to support the health of rural Oregon moving forward.
If I may say, my understanding of what you brought to us is that you have an organization in Eastern Oregon right now that has been up and running for a while, and you are basing this new entity on what you have already seen work in Eastern Oregon. Is that correct? Okay.
Absolutely, yes.
And then a couple comments come to mind. One, and this ages me, I guess, but you know, the parity law was passed when Senator Wellstone was still alive. Mm-hmm. And I worked in an office in the 90s, which was talking about looking at the whole health. So I am a little chagrined and pleased, I guess, finally, that in 2019, we're talking about, and I know you all have been working on this for a long time. It's not just something that's new today, but if you care to comment, and I'm sorry I didn't give Mimi a chance to talk about this, but you know, mental health is brain health, it's body health, it's physical health.
Just a couple things. Number one, I have the honor of serving on the National Council for Behavioral Health Board of Directors, and so parity still at the federal level is a very frustrating issue, and it unfortunately, and I'm going to take a bit of a risk here, but I'm very familiar with Davis-Bacon laws and prevailing wage laws when it comes to public contracting, having been a county judge in an earlier life. Unfortunately, we didn't have those prevailing wage laws when they followed human beings from institutional levels of care to a community-based level of care. And it's an uphill battle, not just in behavioral health parity, but also in paying for early childhood programs. If we can't invest money to recruit our best and brightest for that 0 to 3 population, then we have a real difficult road to travel moving forward. So I'm totally on board with what you're saying. The other piece about it is one of the things we instituted in Eastern Oregon is payment for community health workers. And we were one of the first CCOs in the state to reimburse for community health workers. Those are jobs at rural communities that kids coming out of high school can look at and get place-based education and not have to leave the community. That's one of the other real problems.
Senior care also is very needed.
Absolutely. People having to move away to get the credentials to come back and provide health care is a myth that rural Oregon and other rural parts of the country have suffered, and we have to undo that.
Do you think it's possible that through CCOs or however mechanism, I see one of the problems in caregiving sort of jobs is the wage, even though it's obviously one of the, for sure, growth industries in this country, and the possibility of people being able to afford, like in senior care, $10,000 a month to have their loved one in a facility is just, in my opinion, not sustainable. Maybe it's just the circle I ride in, but I mean, we have to bring up income for people that do caregiving, and that will feed the community and allow folks to get care in their communities. That's my opinion. But
It's an interesting circle. So my background, I was also a healthcare provider before I moved into administration. And I think it's an interesting circle because the more we pay healthcare workers, the more expensive healthcare gets. And at the same time, we're supposed to be reducing the cost of care. So trying to figure out how to, I think the big thing is, and Kevin kind of hit on it, is how do we get some of those jobs that people need to do to work at the top of their license? How do we find other people that can do those jobs and that can be community educated, community familiar with their communities? And so community health workers are wonderful for that because a lot of healthcare is figuring out how to navigate it. And so we've got doctors and nurses that are spending a lot of time helping people navigate the healthcare system. I always wish everybody could get a little angel on their shoulder the minute they walk into anywhere that's related to healthcare that could help them figure out how to navigate all those steps and not need duplicate labs or not need to be waiting for months to get from here to there. And so we're asking our healthcare workers to do that right now. So if we can find, and there's so many really compassionate people that can do this work, that want to do that, pay them well, but not require them to have to go get an RN degree to be able to work in healthcare, I think you can start seeing a lot of those things start changing where we're reducing the costs, but we're also getting people what they truly need, which is not necessarily a nurse. It may not be a doctor. It may be somebody that can check in and say, hey, did you check your diabetes, your blood sugar today?
right. And I agree with you, but I mean, we have to stop blaming the people in the trenches and look at big pharma and look at corporate investment and shareholders. It's not just the people that are actually doing the work.
Not by any means.
The only thing I'd add is anybody that's getting anywhere near my age, I'd recommend you read Atul Gawande's book, Being Mortal. Because if we don't address end-of-life care, if we don't figure out a way to have the conversation with folks as they grow older, and quite frankly, I think that in Oregon and other states that are moving into a more forward-thinking, we need to make a bargain with folks that there are incentives for advanced directives, and there can be a community benefit of you spending less on end-of-life care than the national average. The statistics tell us that we spend more money in the last month of many people's lives than we do in their entire life before that. I think counties and county governments and not-for-profits play a key role And if somebody were given the choice to say, I can go be hooked up to a machine for a month, or I can take the half of that money and invest it back in the kids in my community or the future of my community through the county or not-for-profit, that should be what Oregon is looking at in the next 5 years, not just messing around.
It's also interesting what they have found about loneliness and the effect on people's health. And I know in our county, we have a very serious problem among seniors with, due to isolation and whatnot. And if we can build community, just like both presentations have talked about, of looking at the whole community, that will help raise, as you have both said, raising the boats of everyone involved.
I'm feeling like we've overstayed our welcome, so.
I'm just getting started.
Yeah, I do have a question. So how do you determine, what are the methods that you use to determine which groups you fund? How do you do that?
So I'll let Bonnie talk more about this, but again, the Oregon Health Plan has a prioritized list, which is a guidance. In a managed care environment, you can go beyond that list to provide services that are preventative in nature if you can demonstrate that you're preventing something that would be above line from happening. GOBI is also on the behavioral health side, and NCQ, National Council for Quality Assurance, certified organization. So we use evidence-based practices to look at services and also quantity, quality, and place of service to try to get the right level of care to the right person at the right time.
So this is where I think the data helps a lot. One of the things we obviously look at is somebody that's utilizing a lot of services to kind of figure out what's going on, how can we help. So that's kind of your low-hanging fruit. But one of the other things that data does for us is gives us a chance to look and see where there's rising risk for people. For instance, if somebody's on an antipsychotic medication, we know they're at high risk for diabetes. And so through the data resources, we can look and say, okay, everybody that's on an antipsychotic, have they gotten their diabetes screening done this year so that we can make sure that they're not getting sick? So we're starting to really figure out how to mine that data to look for areas where people, maybe they haven't been to the emergency room in the last 5 years, and all of a sudden they've been 3 visits. So something's going on. Is there something that we can do to help? So we try and use a lot of those kinds of resources to look at how we use our resources within the CCO to support those members in ways that are going to help them get back to their optimum lifestyle as quick as possible. So that's kind of how we do that, is really looking at that. And there's obviously the folks with severe and persistent mental illness that we pay a lot of attention to, people that are dealing with chronic illnesses, so medical conditions, there's COPD and CHF and different things like that. And then when you start getting those combinations, and Mimi had a great graph, when you start seeing those pile up on top of each other, we know those are folks that may need our help. They may not, they may have a great support system. But that's our job, is to check in and make sure that if they don't, is there areas that we can fill. And we've got some amazing folks throughout the community that do that. Then the other thing we do is we've actually, over here, got a couple of people that go out and work, actually are out visiting with folks and seeing if there are opportunities when people are ready to engage. Because a lot of times people are at a spot in their life, they may just not be ready to get help for that substance abuse disorder or that mental illness. But then when they are, there's actually healthcare workers, community healthcare workers that are out in the community around here that are there to kind of help point them in the right direction. Not to provide the care, but just to, again, help them navigate the healthcare system.
I think the final area, and data is great, but this is a community effort. We really have to eliminate child abuse and neglect in our lifetimes. We know the adverse childhood experience data is 20 years old. We know what the outcomes are across all domains of untreated trauma. We know that resilience can be built up through relationships. We have to be, it has to mobilize the communities of this state, and we have to get ahead of that if we're really going to change the curve.
And do you see that this is a trend in the state? There's a strong trend?
Yes, I had the good fortune to serve on the COSA Council of School Administrators work group this last year. social and emotional learning, well-being for kiddos coming into the school system is their highest priority. I think by joining the healthcare world and the education world to talk about how we have common goals that we measure children's health by. I think they need to have a few medical goals to be sure they have their developmental screenings, and we share that data better on the front end. But I think that we could easily adopt and should adopt kindergarten readiness, third grade reading, and attendance in the 6th and 9th grade, which they've adopted as our shared goals. And we ought to have some skin in the game. Just like Mimi talked about those metrics, having some money dependent on what your community partners are doing rather than just what you're doing is probably where we need to go into year 5 of 2.0.
Thank you.
I have,
Oh, yes, Commissioner.
I just have one question. The citizens of Clatsop County were probably very hopeful when the partnership that became the respite center looked like a wonderful collaboration. Recently, Gobi has kind of pulled the rug out from that enterprise. Why should we trust you now?
Well, we didn't pull the rug out of that enterprise. What we had done is worked ourselves into being in a really unworkable situation for Clatsop Behavioral Health, where we were charged with overseeing their performance. We were the landowner, we owned the building, being Gobi, and we had a voice on and a vote on the coalition, the Caring for Clatsop Coalition. So how many masters can one small agency serve? And we intend to be, as long as we're in this community, we intend to be part of the Caring for Clatsop Coalition. We simply stepped back from making taking a decision-making role or having a vote to try to give some space to all that was going on around the respite center at that point in time. And as you're aware, the county was also putting an RFP out for outpatient mental health services. So this was a decision of our board of directors, which I personally support. We in no way, shape, or form intended to pull the rug out from under the coalition. I was at a meeting with Monica, 10 days ago? And I believe that the coalition is unique. It's the first in the state that's had something like this happen. By community partners coming together and underwriting an enterprise such as this. It's just we have to get through some choppy waters to move forward, I believe. As you know, Gobi is currently also trying to unwind our ownership in that building. We intended to own it for a year or two and then have the provider buy it. We've offered to CBH the right of first refusal, and we intend to execute the sale, but we also intend to work with the coalition as that sale takes place to try to optimize community voice in what the provider or owner of that building is able to provide.
I'm
as far as
sorry.
services.
I simply believe that you pulled the rug out on us. And I think that's caused Gobi a lot of ill will in the community. And I think that it might reflect negatively on your application, especially since you come in with co-owners. I don't know what that means for a nonprofit, but.
Well, I'm sorry for doing that, and I apologize on behalf of myself and the board.
Okay.
All right, any more questions?
I just had one last comment. I want to express sorry, I've got a cough drop, my personal gratitude for the good work that you've done in this community. I think that listening to you talk about the scope and depth of, again, your commitment here and in Eastern Oregon, we're really fortunate to have had you working for us. Thank you.
I'd like to make a comment too, if I may. I remember when when the respite center was getting started and how the excitement that was surrounding that building being bought and the hopes that was going to happen with that respite center. And I don't know all the particulars, but I know the community from many different directions wants some sort of respite center, or maybe they'll change the name of it, but some sort of situation there. And I hope that, for me, on the outside looking in, I felt like it wasn't real clear to me. I think there were so many expectations from so many different directions and so many people trying to please so many different directions. It made it very difficult. And so I'm hoping that that the community can resolve this in a satisfactory way. And I don't know what the particulars were in your decision, but I think that was a project that is ongoing. I don't think it was ever, to me, it wasn't ever, it didn't, I don't know if it really gelled in the way that many different people wanted it to. So I think I look at it as ongoing. I hope that's what the situation is.
Thank you.
Thank you.
Do we not have any business from the public? I don't have any green cards.
I wanted to,
Okay.
they know they have to do the green.
All right, so since there's no business from the public, we'll move on to the consent calendar.
Madam Chair, I move adoption of the consent calendar.
Second?
All those in favor?
Aye.
Any against? Consent calendar is approved. Commissioners' reports. Commissioner Sullivan.
You know, I don't have a report today. Thank you.
Commissioner Webb.
I do not have a report today either.
Commissioner Thompson.
Okay, let me break with convention then. I'm really excited because tomorrow there's a group of county commissioners who are going to go with AOC staff and meet with Oregon Housing and Community Services Director Margaret Salazar. It's only a 30-minute window of opportunity, but this is something we've all been working for, and many of the people in the audience. So I hope I carry our best thoughts forward with that. I went to Colpack, Columbia Pacific Economic Development Region, and there's business going on there. I have copies of the agenda and the minutes and all that sort of thing if anybody's interested. If you've been out on 101 South, you will notice that the road crews are out. We talked a lot about communication. ODOT doesn't have the money to push out the information to individual community members. They said what they're going to do is, if you want to call 511 or trip check or all that sort of thing, you can do that. The other thing to do, which I've now done, is to put Waze, W-A-Y-Z, on your smartphone, and that Waze application is going to be receiving information from ODOT, and so it will help guide us as those of us with one lane north and one lane south attempt to navigate our roads with any sense of timeliness this summer. That's happy news, right? I went to a conference on global transformation down in Hollywood, California. I've never been to Hollywood before, so it was really interesting. It's part of my personal stuff. It makes me happy to do it. There was a man there I talked with who's running death cafes, and it's an opportunity for people to, I want to say, get comfortable with the idea of their own demise. And I wonder if that's something that any CCO or any community organization is interested in forwarding. I mean, I know at the Hoffman
We've got them
Center.
here.
Yeah, we've got them here. Just so that there are ways that we as a culture can become more convenient and save that last month's expense and agony in everybody's life. I would like to see that happen. And if anybody wants to see all the cool things I got, I'm happy to show that as well. Otherwise, tomorrow evening is when we have the electeds meeting, so I'll hop to Salem and then I'll hop back on the roads. I'm getting my money's worth from ODOT, so we'll see everybody tomorrow night. Thank you.
I was called out of town, so I wasn't able to go to the Arts Council meeting, but I did speak with the chair and got a recap. They are working towards an art summit for late November, focusing on the business side of art. Also, Gail Hendrickson met with the council to begin a conversation about the arts in the unincorporated area for the updating of the comprehensive plan, or perhaps prior to that, I'm not sure. It's with the comprehensive plan? Yes, okay. And also, looking at updated graphics for the 18 land use goals, which I think is a good idea. And that's all that I have. So let's take a 5-minute break.
Thank you, God.
I don't think God is responsible for that.
Commissioners, please come back to the dais.
She's on the jail.
Oh, I didn't remember seeing
Okay, now we have on page 93, adopting proposed fee
that.
schedule.
Sorry, Chair, can I just do county manager's report real quick?
Yes?
Okay,
You will be allowed, yes.
sorry.
I'm sorry.
That's okay, that's okay. I figured it's all right.
I'm so sorry.
All right.
The only reason is because I have a quick question that I want to get confirmation from each of you on, if possible, is Prothman is wanting to do county manager interviews on July 8th. And I want to confirm from each of you if that would work with your schedules. It would be an
Is
all-day
that a
event.
change?
No,
Okay.
That's when Teresa sent.
yes, yeah. And so if I could just get confirmation so that we can reply to them if July 8th would work with your calendars.
Did we already have that discussion?
Teresa sent out an email.
And we already confirmed?
That's a
No,
Monday.
nobody's confirmed. That's why we're trying, well, sorry, I apologize. Commissioner Thompson has confirmed, but we're trying to, and Sullivan.
Oh, thank you, yeah.
We're just trying to get it scheduled.
Okay, July 8th.
Yes.
Commissioner Sullivan says yes.
It will be an all-day affair.
Oh, yeah, okay.
With food, right?
These are for the interviews?
Yes, for the county manager interviews.
Okay, but we have a session with Prothman before that.
The 19th.
Yes.
Yes, that's already scheduled for June 19th.
I want to make sure I have that.
Yep.
The all-day one is not time scheduled yet. But
That's all day?
That's all day, June 19th?
Oh, no, excuse me, June 19th is 5 o'clock, I believe.
Oh,
Yeah.
The all-day one would be July 8th because of the number of candidates, hopefully.
We hope.
Okay, so. Okay, so June 19th.
July 8th.
And what time is the June 19th?
Beginning at 5 p.m.
5. Okay.
And so July 8th is good for everybody? Okay, great. And then I also just wanted to remind, Commissioner Thompson also did, but tomorrow evening at 5 p.m. at McMinimum's in Gearhart is the county-wide elected official meetings with the cities as well. And then just a reminder to all of you that I will be gone on June 12th for that meeting, and so Pro Tem Chief Deputy Williams will be sitting in this chair. I'm still going to sit back here. Yeah.
Back of the room.
So, and that's all. Thank you.
but he
Thank you.
He has
And
a
I-
gun, so does that mean that we have to pay more attention to him?
You
than we
should,
do?
yes.
I apologize for skipping over your
No
report.
problem. Thanks.
Thank you for speaking up. Okay, now we move on to the fee schedule consideration.
So on an annual basis, we like to bring before the board a proposed fee schedule that will take effect July 1st. We look at the fee schedule on a regular basis, one, to make sure that the fees are covering the costs of the services they're providing, as well as not bringing in more than the services that they're providing. We want to make them cost-effective for everybody. So there are a few services that we will be looking to increase the fees on, and one of those is in assessment and taxation. There is a proposed fee for a foreclosure report fee, and this is to recoup some of the staff time that it takes to prepare this report. It does not come out necessarily in a legible format, and so it takes staff time to generate this report. And then in addition, depending on the time of year, if somebody, is requesting it, it can't just be created one time, because throughout the year, a property may end up selling because we offer it for bid in auction. It doesn't sell at that time, but then somebody provides us with a sealed envelope. Not to mention there are fees, or interest that continues to accrue throughout the year. And so that information as far as the payoff balance would need to be updated as well. So there's a proposed fee to cover those costs.
May I ask a question? on that. I wondered if anyone had looked at automating that. Is it possible to automate it? And if so, how much would it cost? Do we know?
Well, the information would still need to be manually updated and touched because it is automated to a certain extent, but the format that the raw data is coming out of the system in would still need to be updated on a regular basis because it's the system that we have, it's automated to the extent of the data is pulled out of the system, but then the report format isn't necessarily able to just be generated to a user-friendly format because of the type of application that it is.
All I'm saying is, in my experience, good programmers are able to write either macros or special coding that would do that, and I wonder if we've looked at that.
Our IT department works with that on a regular basis, trying to create these reports, and so I imagine that they have. I imagine that they'll continue to look at it if that does end up being an opportunity, but at this point in time, this is the best option that we have.
Sure, and that'll cost money too, so it's just that it would be a more bulletproof system, I hope, and faster.
I have a question too.
Yes.
Given that this is a foreclosed property, so obviously someone's not paying something, so this would just, this fee would go against when they sell the house, it would be added on to.
No, this is for somebody who wants to know what properties are being foreclosed on in the county.
Investors.
Oh, because month by month, the report would change. Gotcha.
Okay, I understand that now, thank you.
Yes. The other fees being proposed are for community development, and this is in regards to the e-permitting system that we will be moving to. This will give contractors opportunity to apply for some of the permits and such online, and so this is getting in accordance with the state's e-permitting fees as well. And then in the public health department, we are adding additional staff, and in the food, pool, and lodging inspections, and that environmental health org unit is 100% fee-based, and so to cover the costs for the increased needs for these services, they are increasing the fees there as well. So staff's recommendation is that the board allow the opportunity for public comment and adopt the proposed fee schedule as presented to the board.
And when would the public comment take
Just
place?
right now,
Just
you
right
say, I would like to call for public comment on this, just so that it's in the record that we have called for public comment,
Okay.
which is required by statute.
I call for public comment. Anyone who would like to speak on behalf of, regarding this fee schedule? Seeing there is none?
I
Have a
had
motion?
one more question.
Oh,
On the fire suppression, where is this at? Costs actually went down.
Which page number?
Oh, you got me. I think it's page 101,
Okay.
that it went down. Is that because they're,
Again, like I said, we're not trying to make money, we're trying to cover the costs of the services that we're providing.
so that's what you determined? Okay, thank you. I know we've gotten a lot of emails about fire suppression, fire awareness, and I thought, well, maybe we've succeeded and we don't.
We're not getting rid of
Doing such
Smokey
a
the
great
Bear. Smokey the
job.
Bear is coming back.
Okay.
so could we,
Madam Chair, I move that the board adopt the proposed fee schedule to be implemented effective July 1st, 2019, as presented.
do we have a second? It is moved and seconded that the board adopt the proposed fee schedule to be implemented effective July 1st, 2019, as presented. Is there any discussion?
I just had one question. I want to know about composting toilets. I'm looking at page 116. Do we contemplate having composting toilets since we're talking about water shortages and...
They are allowed throughout the county.
I know, but I was looking for them in the fee schedule, and I didn't know where they fit. I didn't know if that was an ordinance 901 septic system review. I didn't know if it was some other kind of, I was just looking, because somebody, I'm sure, will ask me, among the friends I have, what's the fee for composting toilets? And I'd just like to be able to answer that question.
It's a good question.
I couldn't answer it, but I can check with staff and get back to you.
Swell, thank you.
Thank you for bringing that up. Okay, is there any discussion? Okay, the pending question is, shall we adopt the main motion that the board adopt the proposed fee schedule to be implemented effective July 1st, 2019 as presented? An aye vote will adopt the motion, a no vote will defeat the motion. The clerk will call the roll.
Commissioner Thompson?
Aye.
Commissioner Webb?
Aye.
Commissioner Sullivan?
Aye.
Commissioner Nebeker?
Aye. So we have 4 votes in favor of the motion and 0 against. So the motion is adopted. Second is the appointments to the Jail Community Advisory Committee, and I have since learned that there are problems with the way this was proposed and written, and I apologize to those who have come and sat through this long meeting, but I would ask for a motion that we move it to the next meeting.
I'd like to make a motion that we postpone consideration of the appointments to the Jail Advisory Committee until our next meeting, our first meeting in June.
And
I'll second that motion. Again, with apologies for the people who've, it's lovely to see your faces, but I apologize to make you sit here and ask you to come back.
It is moved and seconded that that the board postpone the consideration for appointments to the
Jail Advisory Committee.
Community Advisory Committee until next commission meeting.
so there's another,
Discussion.
there's another phrase on there. It says adopt the Community Advisory Committee and adopt the Jail Community Advisory Committee charter.
Well, I think we're just,
Tabling the whole
yes.
Whole
position.
thing.
Okay, all right,
Yes.
very good.
Is there any further discussion? So the pending question is, shall the board postpone the consideration for appointments to the Jail Community Advisory Committee until next commission meeting in June, first one? An aye vote will adopt the motion, a no vote will defeat the motion. The clerk will call the roll.
Commissioner Webb?
Aye.
Commissioner Sullivan?
Aye.
Commissioner Thompson?
Aye.
Commissioner Nebeker?
Aye. So there are 4 in favor, and the motion carries. And there's 0 against. I should have said that the other way around. Okay, now we move on to the appointment of Planning Area Citizen Advisory Committee members, page 147.
Okay. Good evening, Gail Henriksen, Community Development Director. At the March 27th meeting, the Board of Commissioners appointed the original round of applicants to the Citizen Advisory Committees for the Comprehensive Plan update, and you also at that time directed staff to reopen the application period. We did that. We advertised from April 1st through May 3rd, and we received 8 additional applications. The advertisements were done on the county's webpage, our Facebook page, on the weekly bulletin, pretty much every week that goes out to the local newspaper and the local radio stations, as well as personally sending it out to our Planning Commission members who also helped recruit in their areas as well. So I know that you'll notice that one of the 8 applicants does have a Portland address. I do want to point out that that person does own 3 parcels, one of which is in a UGB area, but 2 of which are in the unincorporated area in the Clatsop Plains planning area. So staff is recommending that the board appoint all 8 members to their respective planning area citizen advisory committees, and I'm happy to answer any questions you might have.
I just appreciate that you went back out and cast the net wider. Well done.
Thank you.
Gail, did you have a target number for each of these committees?
We initially, I believe we wrote into the bylaws 3 to 5 is sort of an ideal manageable type of board. I think we will have, Seaside Rural will have 1, Southwest Coastal I think will have 5 or 6, Lewis and Clark will have about 7, Clatsop Plains will have 5, and I'm missing 1. LC Jewell I think will have 3 or 4.
Yeah, that's
good. That's good.
I guess I'm accustomed to seeing a little bit more than that, but do you feel comfortable with this group, or do you think it's worth going out again? You know, do we have a nice mix of business people and big landowners and small landowners and, you know, the kind of variety we need?
Yeah, I think we do have a very good mix of people. A lot of them were at the coastal zone management training last week, and so we had a very good turnout. They're very engaged. They're very eager to begin the process. We do have a couple of those meetings set up already. I think where we do have just a little bit of weakness is Seaside Rural, because we do have just that one person, and we would probably look at holding their meetings together with either Southwest Coastal or LC Jewell so that they can discuss issues they might have in common.
Yeah, maybe LC Jewell would be more, yeah.
And Clatsop Plains as well. Mary Kemmis, for example, has been in Seaside for quite a while. So you'll talk to them; they'll figure it out. It'll be a collaborative effort, I'm sure.
And what's your time frame for you? When are you going to get these folks together?
Well, we've got 2 meetings scheduled already. The countywide advisory committee is going to meet June 20th at 2 p.m. here in this building. The Northeast Planning Area will hold their first meeting June 5th at 2 p.m. at the Napa Fire Station. And we're also doing a Northeast Planning Open House on June 8th, which is a Saturday, at the fire station from 10 to noon. And then tomorrow, once you've appointed tonight, I'll be sending out doodle polls to everybody in the remaining groups to figure out when we can set up the next meetings. So.
Excellent, excellent.
Any further questions for staff?
Madam Chair, I move that the board authorize the chair to appoint members to the Planning Area Citizen Advisory Committees as follows: Clatsop Plains, Mary Kemmis, Jerry Myers, Maria Pinsitich, LC Jewell, Ron Weber, Lewis and Clark, Olney Waluski, Dr. Frank Mansfield, Jim Conklin, Seaside Rural, Connie Moore, Southwest Coastal, Linda Eierman.
Second.
It is moved and seconded that the board authorize the chair to appoint members to the Planning Area Citizen Advisory Committees as follows: Clatsop Plains, Mary Camus, Jerry Myers, Maria Pinsetich, LC Jewell, Ron Weber, Lewis and Clark, Olney Waluski, Dr. Frank Mansfield, James Coughlin, Seaside Rural, Connie Moore, Southwest Coastal, Linda Eierman. Is there any discussion? The pending question that the board authorize the chair to appoint members to the Planning Area Citizen Advisory Committee as follows: Clatsop Plains, Mary Camus, Jerry Myers, Maria Pinsetich, LC Jewell, Ron Weber, Lewis and Clark, Olney Waluski, Dr. Frank Mansfield, James Coughlin, Seaside Rural, Connie Moore, Southwest Coastal, Linda Eierman. An aye vote will adopt the motion. A no vote will defeat the motion. The clerk will call the roll.
Commissioner Sullivan?
Aye.
Commissioner Thompson?
Aye.
Commissioner Webb?
Aye.
Commissioner Nebaker?
Aye. 4 in favor, 0 against. The motion carries.
Thank you.
Good of the order?
I do, yes. I was given an email earlier this week from Ken Starr, who works in the water. He's a hydrologist, I think. He works for the state, and he deals with water concerns. And he sent me an email, which, he sent me 3 emails, which I forwarded on to the rest. I had Monica forward on to the rest. And I don't think there's something that we need to make a decision on tonight, but what he said is, I wanted to bring to your attention that, that the state of Washington has declared let me get his wording, so
Yeah.
it's better than what I'm going to,
They've made an emergency declaration.
yeah. Let me see. He said, I saw that Washington State had declared a drought right across the river from you. It might be a good thing to bring up with your fellow commissioners. In Oregon, the drought declaration process starts in the county commission level, and I gave him a call, and he gave several different links to the concerns. And I know that when I have attended the Board of Forestry meetings, when they talk about fire risks, they're always talking about what the water levels are, what the drought conditions are, and they've been a concern for a couple of years now, statewide. And so what he was saying is, if Washington State is doing that we need to keep an eye on it. Now, it looks, it doesn't look like drought weather here today, and if it gets rain, it looks fine, but the overall climate he said if that, a couple weeks ago when we had that 80, 90 degree weather, which is so out of season, if that weather pattern were to settle down into this area, it could be, it could bring a lot of water concerns. And so if that were to happen, one of the things that my understanding is that the county commissions would get together, talk about it, and then it would be referred to and I'm sorry, I'm not good on the names. There's a committee that would come in from the state and look at the water levels of the creeks and look at the different things that they look at and say, yes, I think there is a problem here. And then it would go to the next level, who would discuss it, and then eventually it would go possibly to the governor's desk. And if we were in an emergency drought situation and it was declared, that allows for people that are impacted from the drought to possibly get grants or some funds to recoup the losses. In 2015, it was a really tough year for the fishermen, and some of that. So I just wanted to bring that to your attention, and so I shared that information with you all, and I also shared it with our emergency management director, Tiffany Brown, and she asked, what am I hearing from the farmers, and I don't know what Commissioner Thompson is hearing. I happened to run into Commissioner Roan last night, and he said that for him, a dry winter works well for him because it's out in Brownsmead. It gives him a little less mud. So I just wanted to keep an eye on it, because the one thing that the Ken Starr said is that, that things are changing, and what we assume to be just the norm, that's shifting a little bit. And so what can we depend on may be different in the future. And so we need, since it gets triggered by the county commission level, I just want us to keep an eye on it and the ears open and see if we need to move forward on this.
Madam Chair, could I? Commissioner Sullivan, I appreciate you raised this issue, because we know that climate change is happening. We know that we're going to have more heat, less rain, more rain. I mean, it's just, the system is wobbly on its axis now. So I gave Susan Morgan a call, because she's been dealing with this as a county commissioner and a state legislator, and now as an AOC staffer.
And she's been very good at sending the water reports out.
Yeah. She does. And she just sent me one more thing, so I'll try and get that passed on. I don't know. She asked about the data we need, and so looking at getting data, because this is quantifiable measures, so we appreciate that. The process number 2 that we need to go forward, the purpose of the program, our involvement, so that we have some kind of structured sequence of actions to guide our deliberations. And then 3, the economic and social impacts. I mean, we've got farmers, we got timber folk, we got firefighters. I mean, I thought about the ODF has their forest land fire unit, Neil Bond and those folk, but our local volunteer fire districts and the Fire Defense Board, I mean, I think it makes sense that we proliferate conversations around the county, because this is big news for all of us. So thank you for raising that.
Yeah, I appreciate that, and I think they had a letter from Commissioner Hall down in Lincoln County? Lincoln County, and when they asked for this declaration, I believe it was in 2018, they had to have very compelling reasons for doing this. This is not something that's just done, well, hey, why don't we do this? They have to have very compelling economic and social reasons to have this. So you're right, there is structure to doing that, and but I just think we need to keep an eye on it. And I think it's like with Arch Cape asking, working on trying to buy their watershed. Water is going to be I'm not the first to say this, but water issues are the upcoming issue worldwide. So,
do we have anything else for the good of the order?
Well, I just have a question on this.
Commissioner.
Monica, who would be appropriate in our staff to be monitoring this?
I think the state does it. Right?
Yeah, the state does it, but emergency management from like a drought perspective, kind of from a fire perspective, kind of is aware of some of those things from the state. But she reached out to Steve Meshke with our fisheries just to see if they're noticing anything in regards to the lake and creek levels as well. And so I don't know if he followed up with her, but I can follow up just to check with him as well.
It would just be nice to have kind of a point person on the staff. And probably, I would assume that there's either an ORS or probably a regulation about this issue that we need to, and Susan should be able to help us.
But I also say that when I talked to him, he said that this email that I happened to meet him in another meeting, all those meetings you go to, we started talking, so he just thought of me, I think. But he said that if something like this is sent to the emergency management directors in all the counties. So I think that Tiffany Brown would be the point person on this, because she's in regular contact with the fire departments and whatever, and Steve Meskey, of course, would be able to help her with it.
But also the Soil and Water Conservation District. Right. Chris, nice for you to be here in the audience. Maybe that's, and the watershed councils. There's a whole network of entities, and so it's a big, but it's good for us to be proactive. Thanks again.
Thank you.
Anything else?
Are we done?
Okay, meeting is adjourned.
Thank you, God.